Yeah, Savan, is it live?
Yes, yes.
Yeah.
Now you can start.
Yeah. Thank you. Dr. Aruna and Dr. Sai, with your permission, shall I start now?
Yes, please.
Yeah. Thank you very much, ma'am.
Unmute.
Good evening, all. This is Dr. Someshwar from Shield Healthcare. Welcome you for today's PCOS and endometrial cancer webinar. And with this, let me tell you one thing that Shield Connect has growing beyond the products and making science with innovation. And with this, we want to make a scientific discussion with one-on-one interaction with the doctors. So now we have planned PCOS and endometrial cancer with our eminent speakers, Dr. Aruna Kumari and Dr. Sailakshmi Daayana ma'am. And now today we have two topics. One is in PCOS in adults, PCOS in obesity, as well as PCOS hyperandrogenism and PCOS endometrial hyperplasia and endometrial cancer. So now let me introduce our first speaker, that is Dr. Aruna Kumari ma'am, who is a consultant fertility and gynecologist at Neeravati Hospitals, Nandyala. She's a fellow in reproductive medicine from ICOG Bangalore and fellowship in reproductive medicine from IMA AMS, master certificate in reproductive medicine, Somerton University NHS, and life member of FOXY and life member of ESAR. So now with this, let me turn over the time to Dr. Aruna Kumar ma'am to talk on first topic, that is PCOS in adolescents and adults, that is 15 to 25 and 25 to 35 years of age, as well as PCOS and obesity. Over to you, Dr. Aruna Kumar ma'am.
Hello. Hello.
Yes, ma'am,
ma'am.
you can start, ma'am, now.
Hello. Good evening to all of you. A warm welcome to all of you for this scientific session. I'm Dr. Aruna, consultant at Neeravati Hospitals, Nandyal. Today's topic is PCOS in adolescents and adults. PCOS is a multifactorial disease. Both genetic and environmental factors play a role in the expression of the disease. This is the most common endocrine disorder. To be frank, it's not a disease, but it's a spectrum of symptoms. It has lifelong implications with increased risk of infertility, metabolic syndrome, type 2 diabetes mellitus, cardiovascular diseases, and endometrial carcinoma. PCOS affects 6 to 15% of women in reproductive age and 6 to 18% of adolescents. Adolescence is defined as period between 10 to 19 years of age as per WHO. Coming to the etiology, as we know, PCOS is a multifactorial disease. Etiology is complex and it involves two hits. The first hit is congenital predisposing hit. Second one is postnatal provocative hit. Heritable traits, gene variants, heritable traits and gene variants affecting ovarian function, heritable traits and gene variants predisposing to insulin resistance, obesity, and type 2 diabetes mellitus, congenital virilization, disturbed fetal nutrition, they contribute to congenital predisposing hit. Hormonal changes such as hyperinsulinemia and puberty contribute to the postnatal provocative hit. Coming to the etiopathogenesis of PCOS, as we know that genetic, epigenetic changes and lifestyle cause hormonal changes, which is exacerbated by obesity. This in turn causes low-grade inflammation, hyperandrogenism, and insulin resistance, in turn leading to hirsutism, acne, oligo or anovulation, menstrual irregularity, subfertility, metabolic syndrome, type 2 diabetes mellitus, and increased cardiovascular risks. This in turn causes psychosocial issues. Coming to the phenotype of PCOS, across the lifespan in comparison with controls. PCOS genetic factors and in utero programming are the predisposing factors. During childhood, these children have increased levels of AMH. During puberty, they suffer from premature adrenarche, hyperandrogenism, increased GnRH pulse frequency, increased AMH levels, ovarian volume, hyperinsulinemia. Whereas during reproductive years, they suffer from irregular cycles, hyperandrogenism, subfertility, and infertility associated with increased levels of AMH, antral follicle count, and ovarian volume. During postmenopausal years, there is increased prevalence of hypertension, diabetes mellitus, and these women have increased levels of triglycerides. In non-PCOS patients, that means in normal children, during their puberty, they have acne, increased ovarian volume, irregular menstrual cycles, insulin resistance of puberty, which is physiological. During reproductive years, they have decreased androgen levels with increasing age, decreased AMH, ovarian reserve, and antral follicle count with increasing age. During postmenopausal years, increased cardiometabolic risk factors increase with increasing age with menopause. Fetal programming takes place during intrauterine period. Usually, these children suffer from IUGR, are born small for gestational age. Coming to the clinical manifestations during childhood, these children have insulin resistance, adipose tissue dysfunction, excessive postnatal catch-up growth, premature adrenarche, premature pubarche, and premature menarche. During adolescence, these children have excessive weight gain, visceral adiposity, irregular menses, dysovulation or anovulation, acne, seborrhea, hyperandrogenism, and hirsutism. During reproductive age, most of them are obese, have carbohydrate intolerance, dyslipidemia, suffer from infertility and pregnancy complications. During postmenopausal age, they suffer from type 2 diabetes, dyslipidemia, cardiovascular disorders, hypertension, and endometrial cancer. Neuroendocrine factors, diet, CNS programming, epigenetic changes, genetic variants, inflammatory factors, environmental exposures, exercise, activity, hormonal exposure, ectopic fat storage, adrenal factors, androgen excess, ovarian factors, insulin secretion, insulin sensitivity, all these factors contribute to PCOS phenotype. Coming to the various phenotypes of PCOS, phenotype A, classic PCOS, is characterized by all the three features of clinical or biochemical hyperandrogenism associated with oligo or anovulation, ultrasound evidence of polycystic ovaries. Phenotype B is characterized by clinical or biochemical evidence of hyperandrogenism, evidence of oligoanovulation. Phenotype C is characterized by Phenotype C means ovulatory PCOS is characterized by clinical and or biochemical evidence of hyperandrogenism, ultrasonographic evidence of polycystic ovaries. Phenotype D, non-hyperandrogenic PCOS, characterized by oligoanovulation, ultrasonic evidence of polycystic ovary. Diagnosis of PCOS is very difficult during adolescence, as acne, hirsutism, anovulation, polycystic ovarian morphology are seen in healthy adolescents. Girls with evidence of PCOS within 1 to 2 years after menarche should be assigned a provisional diagnosis of at risk for PCOS and treated symptomatically. Coming to the symptoms of PCOS in adolescents, chief complaint in adolescent girls with PCOS may be hirsutism, topical treatment resistant acne, menstrual irregularities, acanthosis nigricans, and or obesity. Coming to the definition of abnormal uterine bleeding in adolescents, primary amenorrhea is defined as lack of menarche by 15 years of age or by 3 years after the onset of breast development. Secondary amenorrhea means amenorrhea of more than 90 days after previous menstruation. Oligomenorrhea means fewer than 6 periods per cycle during first post-menarche year, less than 8 periods per year during second year post-menarche, less than 9 periods per year during the third year post-menarche. Excessive uterine bleeding is defined as menstrual bleeding that is more frequent than 21 days or prolonged heavy bleeding associated with soaking pads or tampons sufficiently to interfere the quality of life. The international guidelines and recommendations have urged caution before labeling hyperandrogenic adolescents as having PCOS if the menstrual abnormality has not persisted for 1 or 2 years. Prior to that point of time, they recommended that such girls be assigned the provisional diagnosis at risk for PCOS to avoid misdiagnosing physiological pubertal changes as PCOS. Polycystic ovaries themselves have little, if any, clinical manifestation other than their relationship to anovulation. Coming to the evaluation of PCOS in adolescents, they should undergo all these investigations: TSH, prolactin, total and calculated free testosterone, dehydroepiandrosterone sulfate, 17-hydroxyprogesterone, FSH, LH, and estradiol. Once PCOS has been confirmed, OGTT should be done and lipid panel should be done. Adolescents having hirsutism or treatment-resistant acne, irregular menstrual pattern, acanthosis nigricans, and central obesity, one has to rule out PCOS in these patients. If the girl has hirsutism or moderate to severe inflammatory acne, look for whether she is on any medication that can cause hair growth. If yes, discontinue if possible. If no, evaluate her serum testosterone, both total and free testosterone. Screen for non-hyperandrogenic causes of anovulation, FSH, LH, prolactin, TSH, etc. If she has persistently abnormal menstrual pattern, again evaluate for this. Do total and free testosterone. Screen for non-hyperandrogenic causes of anovulation. Acanthosis and central obesity alone. Evaluate for metabolic syndrome. Observe for signs of PCOS. If she develops hirsutism, treatment-resistant acne, or menstrual abnormality, then again she has to undergo these investigations: total testosterone, free testosterone, and evaluation for non-hyperandrogenic causes of anovulation. If she has normal testosterone with abnormal non-hyperandrogenic causes of anovulation, then the likely diagnosis is other than PCOS. If she has elevated free or total testosterone, Do rule out other causes of hyperandrogenism. If she is negative for other causes of hyperandrogenism, then the probable diagnosis is PCOS. If all are normal, she is probably a case of adolescence with physiological changes. Coming to the diagnosis of PCOS in adults, according to NIH criteria, 3 out of 3 should be there. Oligo-ovulation, clinical or biochemical hyperandrogenism, and one has to exclude all other causes of hyperandrogenism. According to Rotterdam criteria, PCOS is diagnosed if woman has any two out of these features: oligo-ovulation or anovulation, clinical or biochemical hyperandrogenism, and polycystic ovaries and ultrasound. According to Androgen Access Society, PCOS is diagnosed if she has hyperandrogenism, either clinical or biochemical, ovarian dysfunction, oligo or anovulation, with or without polycystic ovaries and ultrasound. Coming to the diagnostic criteria for polycystic ovarian syndrome in adolescents. An adolescent girl should have persistent increased total testosterone or hirsutism, or moderate to severe acne, persistent oligomenorrhea for at least 2 years after menarche, or she should have primary amenorrhea by age 16 after completing her pubertal development, PCOM on ultrasound, that is ovarian volume more than 12 centimeters. She should have all these to diagnose her or to call her as a PCOS patient. Coming to the diagnostic criteria, in an advanced age woman, she should have well documented long-term history of hyperandrogenism along with long-term history of oligomenorrhea. Coming to the normal values of serum androgens, total testosterone 20 to 80 nanograms per deciliter, dihydroepiandrosterone sulfate 100 to 300 350 micrograms per deciliter, 17 hydroxyprogesterone 30 to 200 nanograms per deciliter. All these tests should be done during her follicular phase, especially day 2 to day 5. If the 17 hydroxyprogesterone is more than 800, then it indicates that she is suffering with congenital adrenal hyperplasia. The second topic is obesity and PCOS. Men and women each have risk factors that can contribute to infertility, which may be genetic or environmental or lifestyle related. Obesity, one of the most well-known risk factors for infertility. Metabolic syndrome is the result of obesity and is characterized by insulin resistance, high blood pressure, overweight, abnormal cholesterol levels. Most prevalent nutritional disorder of affluent nations as also of developing countries which are undergoing rapid nutritional and lifestyle transition. Broad and significant impact on many endocrinological parameters. Substantial changes in lifestyle. Example, greater consumption of energy, dense foods, and inactive lifestyle are the predominant reasons for the increase in prevalence of obesity and related disorders. Obesity and PCOS. Obesity leading to insulin resistance is one of the major root causes for PCOS leading to infertility. The polycystic ovary syndrome is the most common metabolic abnormality in young women today of reproductive age. PCOS affects 2 to 26% of women during reproductive years. Obesity associated with PCOS results in type 2 diabetes in long term. Obesity, which occurs in 30 to 75% of women with PCOS, increases the magnitude of hormonal and metabolic dysfunction in these women. PCOS even without obesity. Insulin resistance is present in around 65 to 80% of women with PCOS, independent of obesity, and is further exacerbated by excess weight. Insulin resistance has been shown to worsen reproductive and metabolic features, type 2 diabetes, and cardiovascular disease risk in PCOS. The highest incidence of metabolic abnormalities is seen in women with marked hyperandrogenism and anovulation. PCOS is classified as a non-modifiable risk factor for type 2 diabetes. PCOS prevalence and BMI. PCOS associated with excess weight going to cause reduced ART success rate, worsened psychological function, worsened cardiovascular disease and diabetes type 2, increases androgen activity, increases insulin resistance associated with anovulation and oligoovulation. Coming to the pathophysiology of PCOS in obese patients, obesity causes insulin resistance, leading to hyperinsulinemia. Again, it has effect on liver, leading to decreased sex hormone binding globulin production, in turn causes hyperandrogenism. This in turn causes elevated luteinizing hormone, and this in turn causes hyperinsulinemia. All these are interrelated to one another. Insulin resistance is present in approximately 50% of women with PCOS. 90% of obese women with PCOS have insulin resistance. Insulin resistance exacerbates ovulation dysfunction. The clinical manifestations of insulin resistance include acanthosis nigricans, metabolic syndrome, and non-alcoholic fatty liver. Acanthosis nigricans is an indicator of insulin resistance and may be the presenting complaint of patients with PCOS. It is usually, but not necessarily, accompanied by obesity and may precede the onset of classical PCOS symptoms. Obesity in PCOS and its treatment. Diet is the most important one. One has to restrict the calorie intake. It should be restricted up to 1500 kilocalories per day. Exercise is the most important one. One has to exercise for about 40 minutes a day and 5 days a week. Bariatric surgery may be considered for obese PCOS patients who are resistant to drugs. Pharmacological treatment or bariatric surgery not recommended for ovulation induction. Weight loss is the first line of therapy in obese women with PCOS. Thank you. I thank Shield Pharma for giving me this opportunity. Thank you.
Thank you, Dr. Anna ma'am, for the excellent talk. We are very honored and learning to hear you, ma'am. So, Dr. Sailakshmi ma'am, do you have any questions?
Can I ask at the end?
Okay, sure, ma'am. So, can we go ahead with your talk, ma'am?
Sure. Yeah.
Yeah. So first, we'll we'll give the introduction, ma'am. Then we'll start. Dr. Aruna ma'am, could you please stop your screen sharing, ma'am?
Okay. Stop. Mute.
Can you see the screen?
Ma'am, if you could stop your screen sharing, then
Stop it.
yeah, ma'am. First, we'll give the introduction, ma'am. Then you can start your screen sharing. Yeah. Thank you, ma'am. Sorry. Yeah. So now let me welcome our today's speaker, Dr. Sailakshmi Daayana, who will be talking on hyperandrogenism, PCOS, and the long-term consequences. That is PCOS, endometrial hyperplasia, and endometrial cancer. So Dr. Sailakshmi Daayana, she graduated from Usmania Medical College, Hyderabad, and following this, she has pursued her higher degrees in obstetrics and gynecology and gynecological oncology in UK, MRCOG and MD from University of Manchester, subspecialty training in gynecological oncology. And she trained and worked in UK for almost 18 years. And her last post was as a consultant in surgical gynecological oncology for 3 years at St. James Institute of Oncology, Leeds, UK. Since she has moved to India in September 2016 and has taken up the post of consultant surgical gynecological oncology at Apollo Institute of Cancer, Hyderabad. And Dr. Daayana, she is a cancer surgeon and is experienced at performing open, laparoscopic, and robotic procedures for gynecological cancers. That is ovarian, uterine, cervix, vagina, and vulva. She is also a trained gynecologist with 20 years of experience and is expert in dealing with menstrual problems, pelvic pain, and menopause issues. She is ardent about the promoting women's health and well-being. She has taken keen interest in making the women aware about the cancer screening and options and risk reducing options. She is also excellent health and counseling for the patients. With this, we welcome you for today's webinar, ma'am, and over to you for your talk on PCOS, hyperandrogenism, and endometrial hyperplasia and endometrial cancer. Over to you, ma'am.
Thank you, Dr. Som. You're always so kind. Next time, I'll give a shorter introduction to you.
Thank you, ma'am.
Okay, so very good evening, all my friends out there. And Dr. Aruna has talked about PCOD in adolescence and about obesity. I'm going to focus the talk on hyperandrogenism and about the risk of hyperplasia and cancer. As we all gynecologists know how difficult it is to treat a woman with PCOD. This is one condition which seems to be so common, so prevalent. You know, the data says the incidence is 6 to 18%, 6 to 20%, but every alternate teenager I come across has either hyperandrogenism or obesity or acne or period problems. If you go to a college to give a health talk, you see that about 50 to 80% of girls have this problem. Maybe some of them are not PCOD and have some of the other features like Dr. Aruna was mentioning, but goodness me, the number of teenagers and adolescents and even 20 to 30-year-olds with period problems is just so high, especially the oligomenorrhea. It's just baffling how many people have these symptoms. And what's happening? Okay, so we all know that PCOS is associated with hormone imbalance. And before I actually even start talking, I want all of you out there who's listening to this talk to have at least 2 to 3 take-home messages. You know, there should be at least something you do different about your PCOS patients after this session we have had. And therefore, if anything sounds unclear or not correct to you, please interrupt, please let me know, please leave a chat option, because I want all of us to have at least 2 or 3 take-home messages today. And we all know that PCOS causes high androgen, high estrogen, and comparatively lower progesterone. So it is this hyperestrogenism compared to the progesterone levels, which is causing the hyperplasia and carcinoma, and the high androgen obviously causing the male pattern obesity, male pattern hair loss, male pattern excessive hair growth, and the other symptoms we see. And it is again, you know, quite worrying to know that PCOD, the gene defect, could start right from fetal stage. That is why no wonder some of these girls are barely 15 and 16 and they've got male pattern obesity and they're putting weight on. The mothers are absolutely disturbed about how much weight these girls are gaining, how much of acne they have, how rough their skin looks compared to when they were younger. And you think there's more than just a lifestyle problem to this condition. And this is a primary gonadal disorder. So if you start thinking about what do I do to this woman about PCOD, maybe you want to tackle the obesity, maybe you want to focus on lifestyle, maybe you want to focus on the excessive hair, but go back to the root cause. Where is the problem? And the problem is in the ovary. Is that the way the ovary developed? Is that the way the ovary got exposed to something when this person was a fetus? Is that what happened to the ovary during excessive food intake during the postnatal period? We don't know, but the organ to target, if you want to target the disease, is ovary too, in addition to whatever else you're tackling. And it is, remember, a primary gonadal disorder. The problem started with the ovary. Excess androgen secretion, increase in LH, thereby a decrease in FSH. Steen-Leventhal syndrome, we have all learned as med students to check LH-FSH ratios, because in these girls it's altered. And decrease in aromatase levels. What does that do? Androgens cannot be converted to estrogen in the peripheral tissue because the aromatase levels are low. And what happens to these excessive androgens? If they can't be converted to estrogens, they get converted to testosterone. All this excess testosterone in the body is then obviously showing all the male pattern symptoms we see. And this is not uncommon. Not all of them have a beard and a mustache they need to shave. But this picture right at the bottom right, where you see a very faint mustache, you see that a lot. And then some acne, as you see in the bottom left, or very severe acne, as you see in the middle. So you see varying grades of, hair growth and acne due to hyperandrogenism, and the male pattern baldness, where all the hair from the front's going, the frontal, the forehead is receding. They end up having bigger foreheads. And this girl is barely 13 or 14. And look at the back of her neck and look at the side of her neck. And this is a part of the body which is very obvious, which is very visible. Everybody gets to see it. And that's extremely unpalatable to these parents, to the parents, and then to the patients. And what is hyperandrogenism by definition? It is elevation of free or total testosterone above the normal levels. But you don't actually necessarily need to do the testosterone level to find out if someone has hyperandrogenism. Look at their arms, look at their face, and look at their hair loss pattern. Look at the acne, and you do know that there's an element of hyperandrogenism. Like Dr. Aruna said, it becomes important to do the tests when you want to know, is it PCOD which is causing it, or is it something else which is causing it, like a TSH or a prolactinemia? But to diagnose hyperandrogenism, you actually don't need a blood test. And therefore, you look at it clinically, the patient's face and arms and body will tell you if it is, or you measure the androgens, or you do both. And do you have to do an ultrasound to find out if there is an ovarian tumor with androgen levels? You don't. The only time you do is when the hyperandrogenism is to an extent where a young girl is needing to shave on a regular basis. There's a lot of hair around the nipples and on the middle of the abdomen. Then sometimes I might be tempted to do an ultrasound to rule out an ovarian tumor, but not otherwise. And any treatment you give, before you start to decide, I'm going to put this woman on treatment for hyperandrogenism, tell the patient and tell the family that it's going to take minimum 6 months of treatment. That is how long it takes for hair to go and new hair to grow. And therefore, a lifespan of terminal hair is actually 6 months. And that's how long it might take for these people to get better. And how do you treat? Well, we all know obesity, hyperandrogenism, so lifestyle changes. Any PCOD counseling starts with dieting and exercise. Of course, physical hair removal is the easiest and the cheapest. COCP, because start these women on estrogen and then they get better. So COCP, if there are no contraindications and the girl is more than 15 or 16 and is suffering from hyperandrogenism, do put them on COCP without much hesitation, because it does work, and put them on it for 6 months so they see a difference in the hair pattern. You can also suppress their androgens and give medication to lower their androgen levels. And weight loss, how does weight loss help? It increases the sex hormone binding globulin, it therefore reduces the androgen levels, and therefore there's a reduction in hirsutism. And what do COCP do? The overall effect of any COCP is anti-androgenic. The moment a woman goes on COCP, automatically her androgen levels come down. Therefore, if you put them on COCP, you get overall L for 80 rupees per packet. You get Diane 35 for 330 rupees per packet. So you have a choice of drugs there. And obviously what you choose depends on the budget of the patient. These people come from all socioeconomic strata, and we can't end up giving the same thing for anybody. If what you want is a very low budget, then go for the first or second generation, even that works. But if the acne is severe, or they're not responding to first or second generation, or if the patient can afford, then put them on the third or fourth generation pill. The newer type of progesterones work better on anti-androgenic property, and it will work. It will definitely work as long as you give it to them for 6 months or longer. and OCPs that contain third, fourth generation. So remember, if you want to remember something from today, remember that those drugs, those COCPs which have desogestrel, gestodine, norgestimate, or cyproterone. To be honest, by default, most of us these days prefer the third or fourth generation pill. And I only go for the second generation pill when affordability is an issue and I want to restrict their payment to less than 100 rupees per month. I usually go for third or fourth generation. But if I'm prescribing something just for acne or just for hyperandrogenism, then I go for drospirenone. This is one drug which is a derivative of spironolactone. And in the next couple of slides, we will discover that spironolactone is actually a treatment option independent of the COCP. It does work for hyperandrogenism. So if you have a COCP, which actually is a spironolactone derivative, which by nature, by the molecule it has, reduces extra hair growth and acne, and that is what this woman needs, then put them on Yaz or Yasmin. I'm not promoting any drug whatsoever here, but the licensed COCP for acne is both these. The difference between Yaz and Yasmin is the amount of estrogen. So depending on the age group of your patient, you want a low estrogen, go for Yaz. You want a normal estrogen, go for Yasmin. But both of them have drospirenone, which is a spironolactone derivative. And one thing I wanted to just mention is just because you put someone on COCP to reduce their androgen levels and you want to treat their acne and excessive hair, body hair and facial hair, there is absolutely no need to monitor estrogen levels. The patient's face will tell you if they're getting better or not. And they do get better. And anti-androgens, we stopped talking about COCP, we moved on to anti-androgens. We know COCP work, we know weight loss works. What anti-androgens would you give? What is the benefit of anti-androgen when you compare it to COCP? The COCP works on the ovary. The anti-androgens we're going to talk about, they work on the hair follicle, and that is how they are different. So if you see a woman who is severely affected by these changes, then do think about anti-androgens. And what anti-androgens are we going to consider? We'll consider it for moderate to severe hirsutism and spironolactone. It does work, it will work, but you don't want a girl on spironolactone to get pregnant. So you have to make sure that they use contraception. That is why I put them on Yaz or Yasmin, because when they're taking Yaz or Yasmin, I know they can't get pregnant. I know they're going to benefit from the spironolactone. But if I have to give them, say, 50 to 200 milligrams, that is the range you want to give for hyperandrogenism, then make sure that they do not get pregnant. Write it in the notes clearly that you have mentioned it to them, you have discussed contraception with them. This does work when the facial hair or beard type symptoms or the body hair is so severe. You see this kind of desperation in girls who are going to get married and they have highly excessive body hair and so on. And in those cases, there's nothing wrong in considering it for 6 months. Flutamide is another anti-androgen. Personally, I'm not a great fan of flutamide because it can cause hepatotoxicity. If you put somebody on flutamide, you have to do their LFTs on a monthly basis. But if someone has very severe hyperandrogenism and you have tried the third or fourth generation COCP and it doesn't work, then you can put them on flutamide. And why not metformin? Metformin, I don't know how many of you are fond of metformin as a treatment option for PCOD, but I use metformin a lot for my endometrial hyperplasia patients. And I want to bring to your attention that if you want to give metformin, because this girl has hyperandrogenism, she has PCOS and she has hyperandrogenism, and you're thinking what to put her on. For whatever reason, say you don't want to give her COCP, or you have given her COCP and you want to add something for her obesity. I particularly like metformin for obesity. Then realize that this metformin also has an anti-androgen property. It is an insulin sensitizer, and that in itself, that fact that it's an insulin sensitizer might reduce serum androgens. And when you compare metformin to spironolactone, which is an excellent anti-androgenic drug, spironolactone works better. But if you want to treat her obesity and you want to treat her hyperandrogenism, then metformin is not bad at all. And look at it, there are studies which say that metformin and COCP are equally effective for hirsutism. So if you want to treat somebody's obesity and hyperandrogenism and don't want to put them on COCP for any reason, like migraine or gallstones or whatever, you can just put them on metformin for both obesity and the excessive hair. And obviously there is bleaching, there is shaving, there's waxing, the epilators, electrolysis, laser therapy. But if they want permanent rid of this unnecessary hair, then electrolysis and laser remain their only option. And as a gynecologist, I feel it's my responsibility to tell them all this. Because for us, it might look like a small problem, a bit of excessive hair on the upper lip or on the chin, so what? But for the girl, this might be a big problem. Remember, these girls usually are young, usually they are unmarried, and usually they take a lot of pressure from peers. So how much ever you pump them with confidence at home, once they go out and they get a little bit of teasing from their friends, that's it. Their confidence has gone into doldrums, and then that affects their performance at school, at college, and their grades. And you don't want PCOS and what PCOS is doing to them to ruin their entire future. So if a girl comes to me complaining about acne or complaining about unwanted hair, I take it very seriously, because treating that aspect of her PCOS might bring all her confidence back into growing into a very young, confident woman. And those of you who come across a patient who doesn't want to take COCP, who can't go for electrolysis or laser, or who can't go on metformin, and who you can't trust enough to take spironolactone or flutamide, there is something called eflornithine. Something as simple as eflornithine cream. This is not expensive at all. As long as this cream is applied on the excessive hair-bearing parts of her face, the hair growth stops. The only downside of this is the moment you stop using this cream, it starts all over again. But at least this we could do to our patients. So please note that this cream is used to decrease the hair growth. And once the patient uses it for 2 months or longer, you notice that actually there is a visible reduction in the excessive hair growth. What do you do for acne? You do something very similar for acne, because both excessive acne and excessive hair growth on body and face, the cause is exactly the same. Treatment is the same. But the extra you could do is you can reduce the dose of spironolactone to 25 rather than going up to 200 milligrams a day. And you can also add tetracyclines. A month or two of tetracyclines usually does the trick. Our dermatologists are constantly prescribing tetracyclines for acne. And then the isotretinoin creams. We all know how they work for acne. Moving on to my area, which is precancer and cancer. An increasing number of young, obese, polycystic ovary syndrome patients are getting endometrial hyperplasia and endometrial cancer. So when you scan these people and you notice that the endometrial thickness is more than 12 millimeters, you start to worry about them. But if the endometrial thickness crosses 20 millimeters, you have to consider taking an endometrial biopsy. You're thinking this is a young nulliparous woman, probably not sexually active, or probably is sexually active, but the parents think she's not sexually active. How on earth are you going to take an endometrial biopsy? Are you going to put this woman under GA, do a hysteroscopy and break her hymen and go take a biopsy? It sounds ridiculous, but sometimes it's mandatory. What do you do when the endometrium is more than 20 millimeters? And then there's a risk of hyperplasia. This is a headache, constant headache, which we are all facing. So before we come to this stage, if this woman can have minimum 4 to 6 periods a year, this won't happen. So never let a woman have more than 3-4 months of amenorrhea, because we are risking hyperplasia and cancer in them. What causes endometrial cancer? Obesity. We all know obesity leads to excessive estrogens. Excessive estrogens causes hyperplasia. Diabetes is one big risk factor, and PCOS is another risk factor. So what if a PCOS woman has diabetes and obesity? Then where do you go? It's like, a concoction, a formula for endometrial cancer. And these days, there is no simple hyperplasia. There is no complex hyperplasia. There is no nothing. There are only two things: endometrial hyperplasia without atypia and with atypia. The word simple and complex are no more used. If your pathologist is using them, then I seriously would have a word with that pathologist. It doesn't mean, it means they haven't updated themselves since 2014. So never take a report, accept it if it's a simple complex with nothing. There are only two terminologies, endometrial hyperplasia without atypia and with atypia. That is where the classification starts and ends. Don't confuse yourself with simple and complex anymore. And the good thing about endometrial hyperplasia and cancer, endometrial cancer, the type 1 cancer, is it's always in a stepwise fashion. So as long as your pathology report is correct, you know where exactly you stand. And again, I myself say, don't use complex hyperplasia. And then I myself show a slide which uses it. This is because that is ingrained into our heads. We are so used to still the simple and complex terminology. Basically, endometrial hyperplasia without atypia is step 1. Then endometrial hyperplasia with atypia is step 2. And then there's endometrial cancer. And we never jump the queue. It always goes from step 1 to step 2 to step 3. So you have time to act. So thankfully, this is one disease which gives us plenty of time to intervene. So if someone has hyperplasia, what do you do? Forget PCOS. If someone has hyperplasia, what do? You can just wait and watch. You can suggest lifestyle modifications. You can ask them to start walking, exercising, lose weight, and see. This is okay as long as there is no atypia. Or you can put them on progesterone treatment, or you can do a hysterectomy. These are the options we all have had for hyperplasia. Obviously, if there is no atypia, you can wait and watch. As long as you know this woman will come back for follow-up, you can put them on progesterones. And we know that with atypia, we have always preferred to do a hysterectomy. Simple. And what if there is no atypia and what you want to treat them with hormones? Obviously, surveillance. None of us are happy with surveillance. We never know when this woman will come back for follow-up. Less than 3% become cancers. So with no atypia, you're very confidently going to treat them with progesterones. And the best treatment is either you give oral progesterones or you do intrauterine progesterone. With atypia, the risk of cancer is 50%. If any woman has a risk of cancer of 50%, why do you even want to not do anything? Just do the hysterectomy, get on with it. But what if she wants to conceive? What if she is a young PCOS patient? What do? Endometrial hyperplasia with atypia or endometrial cancer. She's a PCOS patient and she wants to conceive. You really feel like pulling your hair out. And this is what I do every day. And maybe that is the reason for my hair loss, because I see this almost on a daily basis. Almost all the fertility specialists in Hyderabad at some stage have sent me a patient with hyperplasia or endometrial cancer because they are young and they are nulliparous. When does the hyperplasia get detected? At the hysteroscopy before the IVF. So they have had PCOS, they have had infertility, they are awaiting embryo transfer. You fertility specialists do a hysteroscopy, send the sample for TB and histology, and then this shows up, and then the patient ends up in my clinic, and then it's not a problem. Yes, we can deal with them, but it is a big hand-holding exercise and a big responsibility. And for how long do you treat them? How long do you treat these patients who have hyperplasia and PCOS? Until their PCOS is cured, obviously. When will their PCOS be cured? When will they become slim and normal? It's so difficult. It's so difficult to define a time point. And I've only put 2 studies to show you because both these studies are very important studies. And one is a meta-analysis and a systematic review, which took hundreds of studies into view. And it clearly says that women of all ages with PCOS are at increased risk of endometrial cancer, even if it's a 20-year-old, 25-year-old, whatever year old. If the PCOS has been long-standing, the risk of endometrial cancer is there. And what causes this? It's excessive estrogen, obesity, and diabetes. We have all discussed this again and again. I want to bring this other study to your attention. Just look at these numbers, okay? This is a study where they looked at PCOS patients versus, this is, and the previous study as well, the meta-analysis says PCOS, increased risk of endometrial cancer, but no increased risk of uterine, ovarian, or breast cancer. And again, this study says the same thing. So they looked at 8,000 PCOS patients. 8,000 is a big number. And then they compared the same age group with 32,000 non-PCOS patients. And interestingly, these are the number of cancers they saw. So if 226 out of 8,000 PCOS patients have cancer, endometrial cancer, we're looking at 33%. So 33% of PCOS patients had endometrial cancer eventually, compared to far less in the non-PCOS patients. So you're looking PCOS patients, there is a very high risk of endometrial cancer and endometrial hyperplasia, and you do need to pay attention to this. And you need to realize that this is a younger cohort who probably also have infertility and who probably want a child and want to keep their uterus. And can you actually treat them with hormones instead of removing their uterus? And yes, you can. We've been doing that. The entire globe has been doing that. There are thousands of papers, thousands of gynae-oncologists who will give you very, very good success rates with hormone management, provided you're dealing with stage 1A and proven on MRI scan, and grade 1 and type 1, which is the endometrioid. So how do you treat them? You either put them on Provida, you either give them Megace, or you insert an intrauterine Mirena. These are your three options. If you want to start doing this for your PCOS patients with hyperplasia or cancer, please do it, but follow the protocol. I always follow the Rcog protocol, and the protocol says Mirena for a year, or Megace 160 milligrams per day. Megace in India is called Endase, or Provira 200 milligrams per day, any of them for 1 full year. You have to take an endometrial biopsy every 3 months. Do that in the clinic with a Pipel aspirator. And the moment you've reached the end of the year and you have had normal reports, especially the final report, endometrial biopsy is normal, the first thing you want to do to these women is, the moment they start menstruating, they need to undergo IVF. So if the woman doesn't have frozen embryos, whilst you're treating them with progesterone, send them for oocyte stimulation and some egg stimulation. If my fertility doctors do that, while the Mirena is in, they do egg stimulation and collect the eggs. If your fertility doctor won't do it, or you don't want to do it, then collect the eggs before you start treatment with progesterone. You should not then stimulate these women for oocyte collection after the treatment with progesterone. That should be done before the treatment, and then start your progesterone treatment. If the endometrium becomes very thin and atrophic, give them some estrogen, let them have a period, then do your IVF. Don't then tell them you're now normal, go have a baby on your own. No natural conception after this, because you don't have that much time. These women can then become hyperplasia all over again. And the other important thing is, once they have had a baby, do the hysterectomy, because their risk of getting the same thing is again very high. And you can get almost up to 40% success rate with pregnancy in these ladies. Some papers say give up to 400 to 800 milligrams of Provida, but Royal College guidelines is 200. Megestrol is 160 milligrams, or Mirena. And almost all my 3-month biopsies after insertion of Mirena have come back normal, almost 99% of them. And you do manage to reduce the cancer. So the cancer goes away, but will they then become fertile is another matter. And the success rate is around 40%. And this is a Pipel aspirator. It's easily available in India, and it's very easy to do an outpatient biopsy with a Mirena in. You just go around the Mirena and take a biopsy from all the 8 quadrants, and the minimum treatment is 12 months. I never, even if the biopsy comes normal, I never make the treatment for less than 12 months. And these patients relapse. That is why once they have had the treatment, don't wait too long, get them to go for IVF pregnancy, let the child be born, and then do the hysterectomy. That is what all the papers are saying. And it is usually within 24 months that after you stop the treatment, if you don't do anything, if they don't become pregnant, you leave them alone. Within 24 months, you start to see hyperplasia again, unless they have suddenly drastically become non-PCOS. That's very unlikely to happen. And this is what the Royal College is saying, that with Mirena, you can treat early endometrial cancers. Now I've given you three options: Provera 200, Megace 160, or a Mirena. Which one would you choose? Which one works better? And RCTs, I don't go for any study which is less than RCT when I'm taking an important decision. And RCTs have shown Mirena to work better than oral. You think oral might work better, but actually Mirena works better because it goes directly into the uterus. And these tablets are expensive. So you don't know with oral, actually, do people take them? Do they take a break? Or sometimes they forget. Whatever the reason, the intrauterine works better. And does intrauterine cause any more bleeding problems? And it usually doesn't, according to the RCT. Price always should be considered in a setting like India, where patients pay for their prescription. If you put them on Provera for a year, the patient will spend around 75,000 rupees. Megace costs around 60,000 rupees. Mirena costs 3,600. And that's around 16 rupees per day compared to 100 to 200 per day with the other two tablets. So something which is so much more cheaper works so much more better. So it's very clear here what you want to use. Mirena is so much more cheaper than Provera and Megace, and it works better according to RCTs. So again, I don't promote any particular drug, but here the choice is pretty obvious. Why is Mirena so cheap? I mean, it costs $800 in USA. It costs 120 pounds in UK. It's only 3,000 in India. That's because Indian governments heavily subsidized Mirena because it works on cancer patients. And one of the last slides I want to bring to your attention is we are doing for conservative management. We're giving them progesterones, we're giving them for a year, we're doing biopsies every 3 years so that this PCOS patient can actually become pregnant. What are the chances? What percent of them get pregnant? After all this is around 40%. But it's worth a try, because if you never gave her a chance and removed her uterus, she's always going to be unhappy about this. But if you tried and she tried and the fertility treatment failed, then at least it's okay for them to accept that they've tried their best and the doctor has tried their best. And I think everybody deserves a chance. And it has been clearly seen that when you do IVF treatment for PCOS patients versus patients who don't have PCOS, who are infertile due to other reasons, obviously there is a lower risk. And also when you're treating them with the progesterones, people with PCOS, there is a lower rate of conversion to complete response. When you're treating them with Mirena or oral progesterones, it takes longer for them to respond compared to other women who are treated similarly. Why else would you? There might be a patient with hyperplasia without PCOS to whom I might be doing the same treatment and they respond better. And the recurrence rates are higher in PCOS patients. They very quickly get back the hyperplasia or cancer if you don't treat. I'm going to end with 2 slides. This particular lady, this is a hysteroscopy picture from earlier this morning. I did her hysteroscopy because she had persistent heavy bleeding. This lady had treatment with me for endometrial cancer stage 1A grade 1 2 years ago. So we treated her with Mirena for a year. All the 4 biopsies I did at 3 monthly intervals were normal. She had embryos preserved. The next thing she was supposed to go was for embryo transfer. She went for embryo transfer and she miscarried. After that, I could not get in touch with her. She blocked me. She didn't answer my phone calls and I didn't know what happened to her. 2 years later, she gets in touch with me to say that she's now bleeding heavily again. And after one failed IVF, the pandemic started. So she didn't go for any more IVF treatment. She didn't go any more treatment. She's working from home. She's far more obese than what she was 2 years ago. And ultrasound scan showed a very thickened endometrium, and hysteroscopy today shows something like this, which I'm sure is a cancer. So if this biopsy comes back as cancer, I'm going to do an MRI to stage her endometrial cancer. And then you see many, many good stories to have more than 45 patients who have undergone conservative management for endometrial hyperplasia or cancer. And this is a WhatsApp message I got from somebody who said, I treated her with Endase. Then she had healthy twins. The twins are 6 months old. Now she's got some kind of problem. If she's had twins and she's had hyperplasia, she should have had a hysterectomy. Why didn't she have a hysterectomy? Because they don't get in touch with us anymore. If you want to get in touch with them and you call them, they either block you or they don't respond to you. They don't answer your phone calls because then they don't want to have a hysterectomy. This is a problem I face with patients in India where they undergo treatment, they go for IVF, and whatever happens after that, they don't want to be in touch with you. How much ever you tell them that there's a risk of recurrence. So every time you're treating a patient with hyperplasia or with cancer conservatively, there is that fear that will this patient come back for the definitive treatment? Am I doing any harm by not doing a hysterectomy at the end just because I can't get hold of the patient? And for the entire year, they put so much pressure on you. They're constantly calling you, bothering you worried about what might happen. But there are success stories. These women do conceive and they do well. So please be there for them and do offer them conservative management. And if you're not in a position to send them to a gynae oncologist, we have had many success stories. And so far, I've not heard of anybody in whom the cancer has come back and their life was in danger. So we do take care of people with this kind of scenario. And I'm now open to questions.
Thank you very much, ma'am, for your excellent talk. And we are very honored to have you for today's webinar, ma'am. I'm very enlightened with your talk, ma'am. Actually, from the webinar, I understood that should be a very close relation should be between the gynecologist, the fertility specialist, and the gynec oncologist for the better clinical and outcomes of the therapy. So as we know that making a distinction between the hyperplasia and true precancerous lesions. So there could be a early identification for the cancer is needed. Further, there should be a very close monitoring as well as the communication between the gynec oncologist as well as the fertility and gynecologist. So thank you very much, ma'am. So for giving a very valuable insights into this PCOS, hyperandrogenism, and endometrial hyperplasia and endometrial cancer, ma'am. So if you allow me, ma'am, we'll take the questions from the delegates. So let me allow all the participants to unmute themselves so that they can have one-to-one interaction with you all, ma'am. And we have a few questions from the chat box.
Yeah, I want to answer one question, which I think is very important from Dr. Sudha. Dose of medroxyprogesterone, Pravira, without atypia could be anything between 20 to 40 milligrams per day. And how long you treat for is a matter of debate. You never know when they get rid of hyperplasia. I would treat them for a minimum of 3 months and then span, if necessary, repeat the biopsy. So the dose is 20 to 40 depending on the patient's body weight.
Yeah, thank you, ma'am. We have questions. That is first one. I think this is for, I guess, Dr. Aruna, ma'am. Any data confirming the importance of measuring ovarian blood flow to the blood flow to diagnose PCOS?
Hello.
Hello. Yes, ma'am.
Ovarian artery pulse peak systolic velocity is seen on day 2 of cycle. If it is more than 5 centimeters per second, then we can think that she is suffering from PCOS. High peak systolic velocity of ovarian stromal artery indicates that she is suffering from PCOS, and she will hyper respond to the treatment.
Thank you, ma'am. And there's one more question. That is cutoff of FNPO in diagnosing PCOS.
These days we are using high-end machines. So these high-end ultrasound machine show all the follicles of the ovary. According to Androgen Access Society, FNPO to diagnose PCOS is 25.
Okay, ma'am. Ma'am, if anybody using, the older technology of ultrasound machine, so what is that cutoff value for FNPO, ma'am?
12. If the ultrasound machine is a lower end one, FNPO is 12.
Okay, thank you, ma'am.
Per ovary.
And I guess we have one more question, I think from Dr. Lakshmi Saujanya. that is role of CO with combination of extrovert and ciprotrione for hirsutism. I think this is for Dr. Sai Daayana.
Role of COCP, ciproterone, to my knowledge, is Dian 35, and ciproterone also comes under third generation COCP. Extremely good for acne and hyperandrogenism. And of course, for contraception too. So any girl, when I prescribe COCP, I ask them, do you have any issue with your skin or hair? And if they say yes, I give them third generation with ciproterone. Dian 35 is my favorite. If they say, no, I have good skin and hair, no issues at all, then I put them on second generation, which is much cheaper.
Thank you, ma'am.
I have a question for anybody, including Dr. Aruna. When are you comfortable putting a young girl on COCP? From what age onwards?
Depends upon the severity of the complaints, ma'am. If she has severe abnormal uterine bleeding, or she is suffering from severe acne, moderate to severe hirsutism, then we can start her on Vosi pills from the age of 16. By that time, she might complete her bone development.
Okay. So from 16, you would be happy to.
Yeah,
because I don't like giving COCP to very young girls thinking they might grow a bit taller, you know. So you don't want to close off their epiphysis by giving them estrogen. But then sometimes they are so bothered, they have exams and the periods come so often or so late, and it totally upsets them. And I think, yeah. So 16, yes, that sounds good. Thank you, Arun.
okay.
Excuse me.
Yeah.
This is Dr. Lakshmi Saujanya from Nandyal. For patients around 40 years who have oligomenorrhea, they get periods only if they take progesterones, patients of PCOS. So is it right to give medroxyprogesterone 10 milligrams once a day from day 15 to day 25 throughout their, means without any time limit?
Ma'am, if that 40-year-old has completed her family,
yes.
A much better option would be to insert an intrauterine progesterone.
Okay, and is there any time limit that we can, if the patient is not willing for Mirena, is there any time limit that we should stop giving medroxyprogesterone? Because I do have some certain patients who are taking medroxyprogesterone for 3 to 4 years.
Yeah. I mean, if somebody has been so compliant and taking it, then I would still highly recommend Mirena to them, talk to them again.
Okay.
But in such people, I would give medroxyprogesterone from day 15 to day 25.
Yeah.
Thank
you.
Thank you, ma'am.
Excuse me, ma'am.
Sure, please go ahead.
I'm Dr. Pushpa from Nandya. Young people PCOS with irregular cycles, but without any like hirsutism or any other complaints. Just they have irregular cycle once in 2 to 3 months like that. In such cases, as we are not much interested in OC pills because of early closure of epiphysis, so for such people, can we prescribe like wait for 1.5 months? If they won't get periods, can we give for withdrawal bleeding like that?
Absolutely, ma'am. That's exactly what even the textbooks are saying, that make them have at least 4 periods a year and 5 days of progesterone and cause a withdrawal bleed. And often I leave the prescription open. I tell the mother, wait for 2 months, get her to exercise plenty. Still period doesn't come, use the same prescription every alternate month, make her have a period. Yes. So what you're doing is absolutely what we are supposed to be doing.
Okay. Thank you.
Because progesterone doesn't cause any effect on the height, and 5 days of progesterone every 2 months doesn't do any damage at all.
And one more question, ma'am. You told how to use progesterone for those who have no ATPR. We have to use continuously.
Continuously, continuously for 3 months.
3 months, okay. And after that, we have to check the endometrial thickness. If it is regressing, how long we should prolong it?
Yeah, if it is regressing, if the endometrial hyperplasia has gone, then don't use it again. But obviously, this is where the lifestyle thing comes. you don't know when this woman will start hyperplasia again. So this is where we seriously have to pump into their head that, look, if you don't modify your lifestyle, this whole thing might happen again, or this might be an occasion for you to put the Mirena in, even if there's no atypia. You worry that this lady might get hyperplasia again, but you don't want to do a hysterectomy because there's no atypia, then use the intrauterine progesterone. It won't do any harm. It will reduce the risk of hyperplasia, provide the woman with contraception if she needs it. It makes her periods light, and then you can stop worrying and sleep better that this woman won't get hyperplasia again.
Thank you.
Ma'am, we have one more question from Dr. BK Sudha. That is, without atypia, with risk factors, oral progesterone is okay or go with hysterectomy?
Again, my personal favorite is intrauterine because it's so much cheaper and you don't worry about patient forgetting to take the tablet or paying so much money for the tablet. So without atypia, it's not worth doing a hysterectomy when you have intrauterine or oral progesterone. With oral progesterone, the worry is how long do you keep giving them for? So if you or your patient, if both of you are keen for or intrauterine progesterone, go for it. Otherwise, do the hysterectomy.
Yeah. Thank you, ma'am.
Yeah, one more question from here. Hello.
Yeah.
See, a patient with endometrial hyperplasia, we are planning to do put in Mirena. Is on the same day, can we take endometrial biopsy EB with people?
Yeah, because if hyperplasia is there, so your two options here are you have hyperplasia with atypia or without atypia.
Okay.
Or you have an endometrial malignancy. If it is hyperplasia without atypia, the intrauterine progesterone works. If it is hyperplasia with atypia, the intrauterine progesterone works. If it is endometrial cancer, the intrauterine progesterone works. But if it is atypia or cancer, and if it is not a woman who wants fertility, you might say, look, I'll do a hysterectomy to be on the safer side. If it is without atypia, then the Mirena will anyway continue to work. So when I take biopsy, I put Mirena in on the same day if I'm doing it under general. But if I'm doing it in the clinic, if I'm taking a biopsy in the clinic, if I'm doing outpatient hysteroscopy biopsy, then I don't put Mirena on the day. I wait for histology, and then in the clinic, I put the Mirena again. But if I'm doing a general, I do both on the same day.
Okay. Thank you.
Thank you, ma'am.
One more question, ma'am. Even when we see endometrial hyperplasia, is endometrial biopsy is required in every case before starting progesterone?
Yes, because if you're dealing with atypia, the first recommended treatment is a hysterectomy. No, sorry, was that your question?
No. I'm like those who have endometrial hyperplasia and ultrasound. We want to start progesterone cyclically or continuously. Is biopsy required in every case?
Yes.
Above 40, yes. If the woman is more than 40, then according to the guidelines, all the guidelines say if the woman is more than 40 and you're suspecting hyperplasia, biopsy is mandatory. Otherwise, legally, you don't have a leg to stand on. But if the patient is less than 40, but the endometrium is very thickened, it looks extremely polypoidal, it's very vascular, then it's always a good idea to take a biopsy. But above 40, you don't have a choice. You have to take a biopsy.
Thank you.
Any more questions from the delegates?
Sailakshmi garu.
Chapanam.
Can I ask you one question?
Absolutely.
How do you take the biopsies?
I take biopsies using a Pipel aspirator. And I do them in the clinic. I give them Dolo, Meftal Spas, and and misoprostol 800 micrograms orally 4 hours before I plan to take a biopsy. Then I hold the anterior lip or posterior lip, depending on anteverted or retroverted uterus.
Okay.
I sound the uterus, I dilate it to Hagar 4, then I put the Pipple aspirator. Then I take a biopsy from like a clock from each hour of the clock.
Okay.
So I get minimum 12 syringefuls, minimum.
Okay. Does the Mirena expel while taking biopsy?
Yeah, if there is a Mirena in, then I don't take a biopsy from 12 o'clock position. I aim to get minimum 6 to 8 quadrants. So I avoid 12 o'clock, 10 o'clock, 11 o'clock. I go from around because I know that my Mirena is usually in the fundal position.
Okay, okay.
And usually once you put the Mirena, ma'am, you notice that not much material comes. Uterus becomes quite atrophic. So how much ever you try, you get very little tissue. You don't see much.
Thank you, Sailakshmi.
Thank you.
Ma'am, we have one more question from Dr. BK Sudha. Post-menopausal, no symptoms, ET more than 12 mm and EB is needed, ma'am.
Absolutely, with all capitals, she does. Yes. It doesn't necessarily mean it's a cancer. If a postmenopausal woman has thickened endometrium and she doesn't have postmenopausal bleeding, then maybe it's not cancer. We see that in diabetics due to inflammation. I see a lot of mucus in diabetics, which gets reported as thickened endometrium on scan. But even if she's bleeding or not bleeding, anything more than 5 millimeters, you have to biopsy, but you can do that in the clinic.
Thank you, ma'am. And we have one more question from Dr. BK Sudha. Procedure of syringing
in Pipelle. Well, Dr. Sudha, the only way I can explain it is, I don't know if you have seen a Pipelle or endometrial aspirator before. You know, I can share my number and next time I'm doing it, I can send you a video of it. Basically, you go into the uterus and then once you touch the fundus or whichever part of the uterus you're holding, then you slowly pull the plunger out and then you go around like as if you're curating. You know, I'll write my number here and please send me a WhatsApp message and I'll show you a video when I do it. I do them so often. And you'll realize that it's extremely easy. It's one of the easiest things to do for us gynecologists. You know, you'll understand it so much better once you say it. I've shared my number to everybody.
Thank you, ma'am. Ma'am, I have a question. That is, sorry. Yeah. Ma'am, can we do, I mean, is it preferable to do supracervical hysterectomy in endometrial intraepithelial neoplasia?
Okay, why do you want to leave the cervix? Tell me.
No, I mean, is it advocated because we have morcellation and endometrial ablations? Whether is it acceptable to treat with this procedure? Because from the
supracervical hysterectomy is done to keep the cervix. Yeah. And the only reason why a woman might want to keep the cervix is for increased sexual pleasure, because some French studies have said that if you remove the cervix, the orgasm is not of the same quality. And none of us know how true that is. That is the only reason to leave the cervix behind. The only other time when people might leave cervix behind is when the bladder is stuck because of multiple previous cesareans and they're frightened to push the bladder down to below the cervix. Otherwise, there's absolutely no reason why you want to leave the cervix. And if you're doing laparoscopic or robotic or vaginal, how will you take the uterus out if the cervix is still in? So supracervical is only possible if you do open or if you want to take the specimen through the abdomen. And especially for endometrial intraepithelial neoplasia, which is a precancerous, you don't want to morcellate that uterus at all. So to me, if there is any precancer or cancer in the uterus, why would you leave a cervix? It just doesn't make sense.
Okay. Thank you, ma'am.
Mhm.
More questions from the delegates? I think there are no more questions from the delegates, ma'am. So if you allow me, then we will close this webinar.
Absolutely. Yep. Thank you.
Yeah, thank you, Sailakshmi, Daayana ma'am, and also thank Dr. Aruna Kumar ma'am for giving us a very excellent talk on obesity and PCOS in adolescents, adults, as well as the PCOS, hyperandrogenism, and the long-term complications like endometrial hyperplasia and endometrial cancer. And I hope this was a wonderful discussion type. So I hope we'll also look forward for your continuous support for upcoming educational activities as well, and we'll continue go with the same kind of discussions in the upcoming webinars as well. Thank you very much, ma'am. I also thank all the delegates for their wonderful participation as well as for the fruitful discussion with the doctors. Yeah, thank you,
Thank you,
ma'am.
Shomesh garu. Thank you.
Thank you.
Thanks.
Thank you.
Thanks, Aruna. Bye.
Bye, Andy.